Good afternoon, everyone. This is Olivia Marquez, and I am a team member with Health Evidence. It is my pleasure today to welcome you to our very special monthly webinar series. Today, we will be discussing colorectal screening evidence and colonoscopy screening guidelines. So throughout the session today, we will be posting polling questions through WebEx, and your participation in the polling questions is voluntary and anonymous. We hope to enable engagement and stimulate discussion throughout the session. So just to let everyone know that after today, the PowerPoint presentation and audio recording will be made available on Health Evidence's YouTube and SlideShare account within the next week. So just a heads up that we will be posting the links to our SlideShare and YouTube account in the chat section of WebEx. So today we are very excited to be talking about review evidence for colorectal cancer screening and the recommendations for screening in primary care. The link to the Health Evidence Systematic Review page and the link to the recommendations are posted in the chat section. So you can click on the links and follow along in the review and guidelines through the presentation today. So just before we get started today, we have our first polling question, and we're asking, what sector are you from? We've opened up that polling question, and you'll see that in WebEx. So just remember to select your response and then click Submit at the bottom of the page. So thank you to those who have started to respond. We see that we have quite a few public health practitioners joining us today, which is great, and a few from research and those who are working in government-related fields. So that's great. We hope to enlighten and hear some questions for those who are working as public health practitioners. So just a few housekeeping items before we begin. Please use the Q&A and chat in WebEx to post your questions or comments. We ask that you please send your questions or comments to all participants and not just to the host. But if you do, it's not a problem. We will still see your post. Towards the end of the session, we will have a question and answer period, and I will be able to read aloud your questions to our presenters to respond. You do not need to wait until the end of the session to post your questions. You can do so as we are going through. We will flag your questions. For the best connection, we recommend that you use a wired internet connection versus wireless. And if you do have any connection issues, you can contact the 24/7 WebEx helpline using the number posted at the bottom of the slide. And this will also be posted in the chat section. So for our audio today, the best way to hear us is through your speakers. You can go to the top of WebEx, and in the top tab, click Communicate, and then Audio Connection. Okay, so we'd like to get a sense of who you're watching or who you're listening to today's session with. Are you just with yourself? Are you with a group of 2 or 3, 4 to 5, 6 to 10, or a larger group of more than 10 individuals with you? So again, thanks to those who are joining. We have, most people are listening themselves, and we do have about 2 people who are joining with a larger group. So that's great. Thanks again for your responses. So it's a special thanks to our Health Evidence team who has brought this session to you today. There's a large team of us who work to keep Health Evidence current and maintained, as well as coordinate our monthly webinar series. So for those of you who are not familiar with Health Evidence, we've launched in 2005, and we are a comprehensive registry of reviews evaluating the effectiveness of public health and health promotion interventions. We provide over 90,000 visitors per year access to over 4,600 quality-rated systematic reviews. We provide links to full texts, evidence summaries, and various other supports and tools for evidence-informed decision-making. One of our main goals of Health Evidence, in addition to making evidence on the effectiveness of public health interventions more accessible, is to make it easier for professionals to use evidence in decision-making. The value added for using health evidence is that we save you time. We have done the work to screen and appraise each review within our repository. We screen all reviews for relevance to public health and keep our repository up to date by constantly screening relevant databases. At any given time, we're no more than 1 to 2 months behind the publication dates. We have done the work for you by critically appraising all reviews through a transparent process, whereby you can actually click on the full quality assessment for each review in our repository and see our rating for our 10 assessment criteria. So healthevidence.org also has various tools and supports for evidence-informed decision-making that are available online. And many users over the years have informed us that our tools and repository are easy and simple to use. So here we've posted a model for evidence-informed decision-making in public health, which consists of 5 components that you see in the diagram. So traditionally, public health practitioners and decision makers do consider evidence about community health issues and local context, existing resources and community and political climate in making decisions about programs and policies. However, it's become apparent that considering evidence about research may be more challenging. So as such, Health Evidence webinar series is designed to identify research evidence relevant to public health decisions to make it easier for you to consider this component in your decision making. So we have up on the slide here is the evidence-informed public health wheel, which illustrates the steps involved in evidence-informed practice. The wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence in the decision-making process. So today we'll hear about how our presenters, Maria and Donna, have worked through the first 4 steps here. So in order to help with the decision-making and with the remainder of the 7 steps. So Donna will be walking us through how she went through defining, searching, appraising, and synthesizing, and we'll hear how Maria has applied this with her team to create the recommendations and guidelines for screening. So we have our third polling question up now, which is, have you heard of PICO-S before? So thank you to those who are responding. We have, most people are saying that yes, they've heard, and we have a smaller proportion who are not familiar. So we'll take a few moments to review what PICO is on this next slide. So PICO-S is a way for you to structure your questions in a defined set of evidence-informed decision-making. And it involves defining who the population is that you are interested in, what the intervention you want to know about is, the comparison group, if any, and the specific outcomes that you are looking for. And sometimes we also have a particular setting in mind. So you may want to consider your question only within the realm of school or community settings. The value of a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which allows you to further articulate specific components of the question that help you to really hone your research question. That way it makes searching for relevant information related to your PICO question. This makes searching for evidence much quicker and easier. So we just have our next polling question before we get started today of how often do you use systematic reviews to inform a program or service? So always, often, sometimes, or you may not know what a systematic review is. So we have a few people who are often or always using systematic reviews, and just a few who don't know what a systematic review is, which is perfectly fine. Hopefully today we can provide some insight into that. So today we are very excited to be having Dr. Maria Bacchus with us today, who is the Associate Professor of Medicine in the Faculty of Medicine at the University of Calgary and a member of the Canadian Task Force on Preventive Health Care. We will also be hearing from Donna Fitzpatrick-Lewis, who is a Senior Research Coordinator at McMaster Evidence Review and Synthesis Center. So with that today, it is my pleasure to welcome Dr. Maria Bacchus with us today. So with that, Maria, I'll pass you the ball and you can begin your presentation. Thank you for joining us.
Thank you very much, Olivia. I'd first like to thank everyone for the opportunity to discuss the Canadian Task Force on Preventive Health Care's recommendations on screening for colorectal cancer. And please stop me anytime if you have any questions or comments. I'm presenting on behalf of our working group, and the members are listed on this slide. I want to highlight our collaborations between the Public Health Agency and the McMaster Evidence Review and Synthesis Center. And you'll be hearing Donna present the review of the evidence. We also collaborate with the National Colorectal Cancer Screening Network. In the next 40 minutes, Donna and I will give you a background on colorectal cancer, describe the methods of the task force. Donna will provide a review of the evidence and key findings. I'll then discuss our recommendations, how we implement the recommendations, and end with our conclusions. And this will be followed by questions and answers. First, some background about the Canadian perspective. In Canada, colorectal cancer is the second most common cause of cancer mortality in men and the third most common in women, with a current lifetime probability of dying from this disease of 3.5% and 3.1% respectively. It's important to note that the incidence and mortality of colorectal cancer are low until middle age and rise rapidly thereafter. And you'll see how that comes into play in our recommendations. It is estimated that 25,000 Canadians were diagnosed with colorectal cancer in 2015, and 9,300 died from the disease. So it's a significant health burden. Now, most colorectal cancers appear to arise from colonic polyps that develop slowly, some of which transform to cancers. So colorectal cancer screening programs aim to reduce deaths by detecting and removing polyps and or early-stage colorectal cancers. Now, the purpose of this guideline is to present recommendations for screening for colorectal cancer in asymptomatic adults, age 50 and older, who are not at high risk for colorectal cancer, and to update our previous recommendations from 2001. And I'll define high risk in a moment. Now, this guideline provides guidance for primary care practitioners on different screening tests, screening intervals, and recommended ages to start and to stop screening. These guidelines do not apply to those who are high risk, and those are people who have previous colorectal cancer or polyps, inflammatory bowel disease, signs or symptoms of colorectal cancer, history of colorectal cancer in one or more first-degree relatives, or adults with hereditary syndromes that predispose them to colorectal cancer, and those are syndromes such as familial adenomatous polyposis or Lynch syndrome. With respect to the screening tests available for colorectal cancer, they fall into two major categories: fecal occult blood testing, referred to as FOBT, and endoscopies. So the first, the fecal occult blood testing, well, that includes GAIAC fecal occult blood testing, or GFOBT, and fecal immunochemical testing, referred to as FIT. In both of these, the patient provides us to a sample that will be tested for blood that cannot be seen with the naked eye. It's convenient and can be done in the patient's home. The next big category are endoscopies. These tests include flexible sigmoidoscopy and colonoscopies. Now, in both of these procedures, a long, flexible tube with a light and camera attached is inserted into the anus, rectum, and lower colon of the patient to look for polyps. Now, before this procedure, patients will need to cleanse their bowel with enemas or laxatives. So you can see the first category, fecal-to-occult blood testing, are less invasive and more convenient than the latter category, which also requires more resources. So let's now focus on the methods of the task force. The task force is an independent panel of clinicians and methodologists with expertise in prevention, primary care, literature synthesis, and critical appraisal. Now, our goal is to apply evidence to practice and policy. For our specific colorectal working group, there were 7 task force members who established research questions and the analytic framework. The working group based its recommendations on the work done by the McMaster Evidence Review and Synthesis Center. I'm going to pass it on now to Donna, who will describe their process.
Thanks, Maria. And thank you for letting me join this presentation. So the McMaster Review and Evidence Center, or as we like to say, MERCY, was tasked to conduct a systematic review of the literature. Before we could start to conduct that review, members of the Evidence Center, the Public Health Agency of Canada, and the Task Force Colorectal Working Group developed a detailed protocol. The protocol is the documented roadmap for conducting a systematic review. This roadmap is one means of reducing bias in the review process because important decisions are made and documented a priori, or in other words, before anyone sees the evidence. The academics and staff at the Evidence Center are methodological experts, and we engage with clinical experts who help interpret the evidence. For instance, data may be statistically significant, but are there clinical meaningfulness in the results? As consumers of practice guidelines, you might want to note who has conducted the systematic review. The philosophical underpinning of having an evidence center conduct the review is that we, the evidence center, do not tend to have a preconceived understanding of what the evidence will show. Since we have no skin in the game, so to speak, there's less bias introduced in the selection of the evidence. Sorry, I'm just trying to figure out how to move my slide.
Hi, Donna. So it's just the very minuscule little arrows at the top of the slide.
Oh, that's right. You did tell me that before. So, oh, I think I just did something weird.
That's okay. There we go. So just at the top of the slide, you might see the title just over from these magnifying glasses, and there's a very tiny little arrow on the side.
I'm sorry, I don't see it, Olivia.
That's okay. So I can flip to the next slide, and you just give me a heads up.
Sure. Okay, that's
Perfect.
great.
Yeah.
So you can go ahead and switch the slide.
That's okay. There you go.
So the review process for all stages of the guideline development, so that's the protocol, the systematic review, and finally the guideline is rigorous. As you can see in this slide, there are many levels of review. This is a critically important step because the production of guidelines can have a huge impact on clinical practice in Canada. This rigorous review process does help to ensure and instill confidence in the recommendations of any guidelines which come from the Canadian Task Force on Preventive Health Care. Next slide. Here we have the analytical framework, or the blueprint of the systematic review. It provides you with a snapshot of the PICO or PICOs, which I will go into further detail in a following slide. The analytic framework is developed and presented as part of the review protocol. It is also an important tool throughout the review and guideline development stages. Next slide. Here we have a detailed slide on the research questions we focused on. In brief, we were interested in understanding the evidence for screening for colorectal cancer with many forms of screening modalities on clinically important outcomes. That evidence includes the benefits and harms of screening, as well as the test accuracy of different tests used in screening for colorectal cancer. Next slide. As stated before, in all systematic reviews, the key to success is getting the PICO or PICOs correct. This slide outlines the PICOs of our systematic review. So just to review with you what Maria has already said, the population of interest were adults who were asymptomatic and or not at high risk of developing colorectal cancer. This meant that studies where patients were going to their primary care provider because they had symptoms such as bloody stools were excluded. As well, we excluded studies where patients had a family history of colorectal cancer, where the patient had a personal history of polyps, and also excluded were populations who had other medical conditions associated with colorectal cancer, such as people with Crohn's disease or irritable bowel syndrome. The intervention of interest includes screening, all kinds of screening modalities. So we looked for studies on primary screening with colonoscopy, CT colonography, the fecal occult blood tests, flexible sigmoidoscopy, barium enema, digital rectal exam, and fecal DNA. For the outcomes of the benefit of screening, we excluded anything that was a test, so follow-up tests. So if the colonoscopy was a secondary test, we excluded that. We excluded case findings or surveillance tests. Also, for the benefits of screening, we included RCTs with a true or no screening control group and a comparison group between two or more tests. For the test properties, we included RCTs, cohorts, and case controls. And for the harms of screening, any quantitative study design was included. The outcomes of interest for the benefits of screening were cancer-specific and all-cause mortality and incidence of late-stage colorectal cancer. Harms included perforation, bleeding, death, false positive, false negative, and overdiagnosis. And the outcome of interest for the diagnostic properties was incidence of colorectal cancer. And from those studies, we extracted data such as sensitivity, specificity, positive predictive value, and negative predictive value. And the setting of interest were primary care or settings to which primary care providers could refer. Next slide. So in order to get to the literature, we had to do a systematic search of the literature. And for these questions, we searched Embase, Medline, and the Cochrane Library for the time period of January 2000 to November 2014, plus a targeted search of Medline for the period covering up to February 2015 for studies in French and English. The search yield was 13,260 citations, of which 9 studies helped answer the question of the benefits of screening, 37 studies informed the question of test properties or test accuracy, and 46 papers provided data on the harms of screening or the harms of follow-up tests resulting from screening. Next slide. How did we critically appraise and analyze the data? Once the studies had passed through many levels of assessment for inclusion and we had arrived at the final set of papers we would be using to answer the review questions, we appraised each study for risk of bias. For this review, we utilized the Cochrane Risk of Bias tool for randomized control trials and the Quadis 2 tool for the studies used to answer the test properties question. For the benefits of screening, we also extracted study characteristics as well as data such as numbers of events, proportions, and percent data, which would be combined or pooled where appropriate to give us an overall risk ratio. The statistical approach for adverse events of screening were also pooled when appropriate to generate summary rates or proportions of harms experienced. And again, the test property data were pooled and a median with range were the summary data presented. Next slide. In our systematic review, we were mostly interested in the body of evidence as opposed to the results of the individual studies. However, one of the ways we look at the body is by understanding and reporting how well the individual studies were conducted. In other words, we needed to understand if there were potential bias in the studies in order to determine the reliability of the reported results. All clinical trials included in this review were assessed as stated by the Cochrane Risk of Bias tool. This tool covers 6 domains: sequence generation, allocation concealment, blinding, incomplete reporting, selective outcome reporting, and other risk of bias. We selected baseline imbalance between the groups and industry funding as the main source of other risk of bias. The information to determine risk of bias was extracted by the primary methodological papers or for each study and by any subsequent papers. And then for each study, one team member completed the initial ratings, and that rating was verified by a second person. Disagreements were resolved through discussion and or a third party when consensus could not be reached. To assign a high or low risk of bias rating for a particular domain, we looked for explicit statements or other clear indications that the relevant methodological procedures were or were not followed. In the absence of such detail, we assigned unclear ratings to the applicable risk of bias domains. To determine the overall risk of bias ratings for an outcome, we considered all domains. However, greater emphasis was placed on the assessment of the first 3 areas, so randomization, allocation, and blinding. In this slide, we have color-coded the answers, with green indicating a low risk of bias, yellow an unclear risk of bias, which generally means that there wasn't anything in the paper that would allow us to make that assessment, and then red as high risk of bias. Study quality is not used as a reason to exclude a study from analysis, but it does become a potentially important sub-analysis category. In those cases, we want to see if there is a statistical difference when we analyze low risk of bias studies against those that are high or unclear risk of bias. Next slide. So these are the key findings for the benefits of screening. So the question was, is the effectiveness of screening colorectal cancer to reduce colorectal cancer, specific mortality, all-cause mortality, or incidence of colorectal cancer? And to remind you, just again, the tests of interest were colonoscopy, CT colonography, fecal occult blood, flexible sigmoidoscopy, barium enema, digital rectal exam, and fecal DNA. We found no trial evidence of the benefits of screening with colonoscopy, CT colonography, barium enema, digital rectal exam, or fecal DNA. For the outcome of colorectal specific mortality, the combined data from the 4 included studies for guaiac FOBT showed a risk ratio of 0.82 with a 95% confidence interval of 0.73 to 0.92. Immunochemical fecal occult blood had only one included study, which showed a risk ratio of 0.88 with a 95% confidence interval of 0.72 to 1.07. Flexible sigmoidoscopy also had 4 studies, which showed a risk ratio of 0.72 with a 95% confidence interval of 0.65 to 0.81. In the next row, all-cause mortality, you can see that there were no difference between those who were screened for colorectal cancer and those who were not. And in the last row, incidence of late-stage colorectal cancer, screening with guaiac FOBT reduced late-stage incidence of late-stage colorectal cancer by 8%, or a risk ratio of 0.92 with a 95% confidence interval of 0.85 to 0.99. Screening with the flexible sigmoidoscopy reduced incidence of late-stage cancer by 25%, risk ratio of 0.75 with a confidence interval of 0.66 to 0.86. Next slide. An important question for the guideline group was, if a test is going to be recommended to be used as a screening tool, how well does it perform against a gold standard test? In the colorectal screening, the gold standard is colonoscopy. To help understand the comparison of the different fecal occult blood tests, we looked at papers that analyzed these tests against colonoscopy. As you can see, these two similar tests also perform similarly, with the exception that immunochemical fecal occult blood tests had higher sensitivity and lower numbers needed to screen than did the guaiac fecal occult blood testing. Next slide. Our search located 46 papers which reported on the harms of screening for colorectal cancer. Generally speaking, all forms of screening have some harm. In the review, there were data for the outcomes of perforation, bleeding, death, and false positive. There are harms associated with these procedures, but these harms are experienced by less than 1%, regardless of whether it was reported by the number of people screened or the number of procedures performed. The exception to this is the false positive proportion of 2.8% for follow-up colonoscopies. Next slide. As part of the guideline development, and therefore the systematic review, there are questions which help to contextualize the evidence for the Canadian setting. An important question to consider is patient preferences and values for the procedure or test. For this question, we searched the literature and found both systematic reviews and primary studies. While the literature found that Canadian respondents mostly agreed with the importance of screening for colorectal cancer, they were not well educated on the types of tests used for screening, with most people identifying colonoscopy as the primary screening tool to be used. Another Canadian study showed that approximately 30% of their respondents preferred no screening, but also said that in screening, their preferences were for little or no preparation, no pain, and that the tests used should be both highly sensitive and specific. Finally, a U.S. study on patient decision-making around screening indicated that the top priority in their decision to be screened was to prevent cancer. Other factors in their decision-making were the avoidance of side effects and harms such as false positives. Other considerations included how often they needed to be tested and the amount of preparation and the actual test procedures. So from this systematic review, and I'm going to pass the slide presentation now on to Maria, the working group took this evidence and built their guideline.
Thank you, Donna. So given all the evidence that Donna has presented, how do we use that information? How do we grade it? Well, we use the GRADE system, which stands for Grading of Recommendations, Assessment, Development, and Evaluation. We're grading two things. First is the quality of the evidence, and the second is the strength of the recommendation. With respect to the quality of the evidence, it's a degree of confidence that the available evidence correctly reflects the theoretical true effect of the intervention or service. And Donna's gone through that slide showing you the assessment of bias. And we rate that quality as either high, moderate, low, or very low. The second thing we look at is the strength of the recommendation, which I will illustrate on the next slide. This slide illustrates how the strength of the recommendation is determined, and it's based on 4 factors to come up with either a strong or a weak recommendation. The first is the quality of the supporting evidence. Second, we talk about the balance between the desirable and undesirable effects. And Donna reviewed the benefits and harms. Third, we look at the certainty or variability in patients' values and preferences. The last factor is the certainty about whether the intervention represents a wise use of resources. And together, they help inform whether or not we give a strong or a weak recommendation. So this table is a guide to how you interpret recommendations for patients, clinicians, and policymakers. Now let's first focus on the first column of strong recommendations. So if we say something is a strong recommendation, for a patient it means that most of you, in fact the vast majority of you, would want the recommended course of action, and only a small proportion would not want that. For a clinician, it means that most individuals should receive the intervention and you should be offering it to all your patients. For a policymaker, it means that the recommendation can be adapted as policy in most situations. Well, what about a weak recommendation? That would mean that the majority of individuals in this situation would still want the suggested course of action, but many would not. So for the clinician, they have to recognize that different choices will be appropriate for individual patients. Clinicians must therefore help patients make management decisions consistent with their values and preferences, and the things that Donna described in the patient preferences should be reviewed with them. Things such as invasiveness of test preparation. For policymakers, it requires substantial debate and involvement of various stakeholders. So before I move on to summarizing the key findings in our recommendations, does anyone have any questions they want to ask about how you interpret grade, or anything that you want to ask Donna about her slides?
So Donna, we've had a few questions posted so far that maybe we can address now while we're closer to that in the session. So Rebecca has posted, if you can please direct her to any information or screening guidelines for those with family history of colorectal cancer. So if you have any ideas or resources of where she could go to find that information.
I don't have any information on that on the top of my head, but I think do you provide my email address?
For sure, yep, we can. We'd be happy to.
Maria would direct
Rebecca.
I was going to suggest there are the guidelines. If you look under the Canadian, the gastroenterology societies, and there's some websites that give some recommendations about screening with a family history, and it's based really on the age of onset of your family member when they develop cancer. And we can send you a link to those sites. If you could, it would be great if you gave Olivia your email. Sorry to interrupt you there, Donna.
No.
No problem.
That's great. We can make sure that your email is made available to participants. So we just have one other question to you, Donna, from Mark Andrew, who's asking if you can comment on the absolute risk reduction and the NNS that you reported in the key findings slide. And his second part of that question is, are these based on a single screen or on a repetitive screening over a period of time?
So the studies they varied. Some of the studies had multiple screens, up to 3, I believe, if I remember correctly. So we would have taken the data, if provided, the way that we analyzed this was we took the most common statistic provided. So if they provided data for one screen and all the studies provided the same, then we would analyze that data. And then separately, we would have analyzed for the longer, the multiple screens. And all of that evidence is in our technical report, which is on the task force website. This is a real snapshot of many, many pages of evidence.
That's great. Thank you, Donna, for your response. That's excellent. We invite participants to continue posting questions as Maria leads into the next section of the presentation.
Thank you, Donna and Olivia. So now we're going to talk about the recommendations based on the key findings. I'm just going to present a summary slide that Donna's already presented, but I want to just highlight the things that the key things that we looked at. So let's look at this slide here. Looks at the various screening tests. This is the fecal-to-cord blood, the 4 randomized controlled trials meta-analysis, and this row is the flex sigmoidoscopy pooled analysis group. If you look then at the colorectal cancer mortality, you can see that the risk ratio using fecal-to-cord blood was 0.82, with the confidence interval right next to that, and with flexible sigmoidoscopy, it's 0.72, with the confidence interval listed next to that. So it's important to just highlight that the evidence from high-quality RCTs showed that both the fecal-to-cord blood testing and flexible sigmoidoscopy decreased the outcomes of colorectal cancer mortality and incidence of late-stage colorectal cancer. And again, note that there were no RCTs that reported on the mortality benefits of screening colonoscopy, CT colonography, barium enema, digital rectal exam or DRE, or fecal DNA testing. In addition, no screening tests reduced all-cause mortality. So based on that and our discussions about how we use GRADE, let's move to our recommendations. First, to remind you, though, that they apply only to adults 50 years and over who are not at high risk for colorectal cancer. And the list of people we excluded are listed there again as a reminder. So this slide lists our recommendations for the defined population. Overall, we are recommending screening with either fecal-to-cord blood testing or flexible sigmoidoscopy. And we divide our recommendations into 2 age groups. So for the first recommendation, we recommend screening adults aged 60 to 74 for colorectal cancer using either fecal-to-cord blood testing, and that could be either GAIAC or FIT, and that's every 2 years, or flexible sigmoidoscopy every 10 years. And this is a strong recommendation based on moderate quality evidence. So a reminder, a strong recommendation means that most patients would want this test, and clinicians should recommend it. Now for those 50 to 59, we recommend the same screening tests, and in fact the same frequency. However, you can see we've separated them into different age groups due to differences in the recommendation strength. This is a weak recommendation based on the moderate quality evidence. So overall, I want to summarize by saying we recommend screening with either fecal-to-cord blood testing or FlexSig in those aged 50 to 74. I want to just now review why we made these recommendations. So in the judgment of the task force, fecal-to-cord blood testing and flexible sigmoidoscopy are both reasonable screening tests for patients aged 50 to 74 based on the RCT evidence. Or why split them into 2 age groups? We did this because it places a relatively higher value on the different balance of benefits to harms by age, and places a relatively lower value on the added complexity of 2 recommendations rather than 1. Although the relative benefits are similar for older, those aged 60 to 74, and younger, those aged 50 to 59, the absolute benefits are going to be smaller in those 50 to 59 due to the lower incidence. So this warrants a weak recommendations to screen those aged 50 to 59 as compared to the strong recommendations for people aged 60 to 74. In other words, you're going to need to screen more people in the younger age group to prevent colorectal cancer. And I'll show you that in a later slide. Now, this next slide addresses those aged 74 and over. We recommend not screening adults aged 75 years and over for colorectal cancer. And this is a weak recommendation. And note in contrast to the other slide for those aged 50 to 74, this is based on low-quality evidence. So why do we recommend not screening? Major reason is there is a lack of RCT data on benefits of screening in this age group. Briefly, it varied, but the upper ages included were 64, 74, 75, and 80 years for GAIAC fecal occult testing, and 64 and 74 for flexible SIG. In addition, there's a reduced life expectancy in the older age groups. However, the reason it's a weak as opposed to a strong recommendation against is that adults over the age of 74 who are healthy with a longer lifespan, with a longer life expectancy, and in general we usually think about more than 5 years, and if these individuals are less concerned with a lack of reported benefit or the potential harms, they may choose to be screened. So in other words, a healthy 76-year-old it's a reasonable request to be screened for colorectal cancer. Well, what about colonoscopy? At this time, based on low-quality evidence, we recommend not using colonoscopy as a screening test for colorectal cancer. And for those of you who followed the release of our guidelines, you see this got a lot of press, particularly in the United States. And so let me explain why we recommended not screening with colonoscopy. So as you may recall, we talked about the fact that sigmoidoscopy and colonoscopy both look at parts of the bowel. The colonoscopy, you see the entire bowel. So in theory, you think you would detect more. And so it may offer clinical benefits that are similar or may in fact be greater than those associated with FLEX-SIG. However, there is no direct RCT evidence of its efficacy in comparison to other screening tests, in particular FIT. So the evidence is lacking. In addition, there are other issues related to wait times, resource constraints, and a greater potential for harm. However, again, it's a weak recommendation, so patients who are less concerned about the potential harms of colonoscopy and who are more interested in a test that allows a longer screening interval, so 10 years, may still request screening with colonoscopy. Now, this slide lists the number needed to screen for colorectal cancer mortality by age group. And I've listed this slide here just to go back and again highlight one of the things we talked about and show you the impact of the increasing incidence of colorectal cancer mortality by age. So let's focus primarily on the fifth column, the number needed to screen. So if you look at colorectal cancer mortality with fecal occult blood testing as an example, if you're over the age of 60, you need to screen 492 patients to prevent 1 colorectal cancer death. In contrast, if you're less than 60, because the incidence is lower, look at how much more you have to screen, almost 2,700. And the same pattern is seen with flexible sigmoidoscopy. Now, before I go on to discuss some of the harms and the comparison to the U.S., do people have any questions about our recommendations?
So, Maria, I just see one question so far. So we have a participant who's asking that in the absence of RCTs or other screening modalities, why didn't the Canadian Task Force for Preventative Health Care emit an I recommendation, that is, insufficient evidence to determine the balance of benefits and harms?
Thank you for the question. So we discussed that more in the actual text of the guidelines. That at this point we can't make a recommendation, but the task force, the way we use grade is to either make a weak or strong recommendation for or against. There's really no category to say that there's insufficient evidence. When there's insufficient evidence, we really will say it's a weak evidence, a weak recommendation. So there really also wasn't enough information out there. In particular, there's a lot of interest about fecal DNA, and there are no RCT data right now to make any comments about that. When that data does become available, we'll certainly address that. I don't know if, Donna, you wanted to make any other comments around that?
No, I think that you've covered that.
That's great. Thanks, Maria. I don't see any other questions right now, so I think we can go on and proceed.
Thank you. So with respect to the harms of screening, we've talked about the benefits, and as we discussed on that slide about grade, you look at all the other factors, which also include harm. Donna's discussed that, so I won't go into a lot of detail, but the bottom line is there's not a lot of great high-quality studies looking at the harms, but we know that there are risks associated with procedures, particularly invasive procedures such as endoscopies, which include death and perforation and bleeding. Those are quite small, however. And the harms will vary depending on the screening test and the cutoffs used for things like, false positives or false negatives for things such as the FIT and the fecal occult blood testing. So I want to now shift our focus to see how we compare our screening recommendations with others. Now, our recommendations are consistent with our previous guidelines in 2001. The difference is we can put a lot more clarity around the strength of our recommendation based on a number of RCTs that came out since that time. Well, what about the other provinces? What about the provinces, I should say? Well, their screening programs recommend screening with fecal occult blood, and the majority recommend FIT, and that's done every 1 to 2 years. So again, we're consistent with that, and our evidence review supports their recommendations. No province currently recommends screening with flexible sigmoidoscopy, and we do recognize that and know that that will be a resource challenge. Now, the U.S. Preventive Services Task Force published recommendations in 2008, and they're currently being updated. And let's just move on to the next slide to talk about that in more detail. So this column here shows our guidelines in 2015, and these are the U.S. Preventive Services Task Force draft guidelines. You can see that in general at the very top, we are pretty similar in terms of our population and age group recommendations. We're both saying that patients between the age of 50 to 74 should be screened, and their grade A means that there's a high certainty of benefit. For those greater than 75, we recommend not screening, but saying that it's a weak recommendation. Their grade C is similar. What that means is you selectively offer the services based on patient preferences. So the major differences are the screening modalities and intervals. So you can see that they recommend fecal occult blood or FIT every year, where we recommend it every 2 years. And the reason we recommend it every 2 years is that was the interval used most commonly in the RCT trials involving GAIAC fecal cord blood testing. Additionally, RCTs show no difference between annual and biannual screening on colorectal cancer-specific mortality. As a result, we chose 2 years, and again, that's pretty consistent with our provincial guidelines. For FLEX-SIG, we do every 10 years was our recommendation, and they said every 10 plus FIT. There was no literature to look at that of adding FIT with flexible sigmoidoscopy. They recommend colonoscopy, and we do not. And the major difference with this, and again, this was highlighted in the literature and the press surrounding our release, is that the U.S. task force, they included modeling studies and observational data, whereas we only included RCTs. And because of that, they recommended colonoscopy every 10 years. The other important thing with the U.S. is that they give you a menu of options. They don't really recommend one over the other. I'm just going to move on now and talk about implementations, because resources certainly need to be considered. So although we recommend screening with either fecal cord blood testing or flexible sigmoidoscopy, we expect that most Canadians will be screened with either FIT or GAIAC fecal cord blood testing due to the limited access to and availability of flexible sigmoidoscopy. Although flexible sigmoidoscopy is not frequently performed for screening in many jurisdictions, it may warrant further consideration, as it can be completed in the same facilities as colonoscopy and using similar equipment, but without the requirement of a specialist such as a gastroenterologist. In fact, in Ontario, they have a very good nurse practitioner screening program where nurse practitioners do flexible sigmoidoscopy. Overall, screening programs would need to consider the implications of establishing screening facilities, such as training of providers, the bowel preparation required by patients, and the resources needed for FLEX-SIG as compared to fecal cord blood testing. Now, I know Donna touched on this, but this is just so important, the values and preferences of colorectal cancer screening, because you saw that all of our recommendations except one were weak recommendations, so values and preferences are so important. I want to focus really on the first and third bullet point, where we know that in Canadian surveys, Canadians preferred tests that are less invasive, less preparation required, and pain. Those were concerns. So when you think about that, you can see that they are more likely to choose screening with fecal cord blood testing. Additionally, when patients have the options of screening tests, sedation needs, test accuracy, confidence in completing the test, bowel preparation, and frequency of tests may influence decisions. So overall, it's not surprising that most studies show that patients prefer to be screened, with fecal cord blood testing rather than colonoscopy. You know, the bottom line for us is that the best screening test is one that a patient's going to do. So if they're not going to do a FLEX-SIG or colonoscopy, then offering them that test is moot. Well, let's not focus on translating this knowledge to practice. There's no point in us putting all these recommendations if it doesn't get down to the practitioner level. So the task force created knowledge translation tools to support the implementations of guidelines into clinical practice. We have a clinician recommendation table and a patient FAQ that is being developed, and they're available for download in both French and English on the website. So I want to conclude by saying that we recommend that starting at the age of 50, primary care providers should discuss the most appropriate choice of tests with patients who are interested in screening. Screening for colorectal cancer with fecal cord blood testing or flexible sigmoidoscopy reduces colorectal cancer mortality, and the direct harms associated with these tests are minimal. The strong recommendation to screen adults aged 60 to 74 with GAIAC fecal occult blood testing, FIT, or flexible sigmoidoscopy indicate that primary care providers should offer this service to all individuals in this age group. We recognize that some may choose not to have the tests because of their preferences, but they should certainly be offered that because of the mortality benefits. The weak recommendations to screen adults aged 50 to 59 with these screening tools indicates that a more nuanced discussion of the harms and benefits will be required. Now, starting at the age of 75, primary care providers should discuss individual screening preferences. We recommend not using colonoscopy as a screening tool at this time based on the lack of high-quality RCT data. There are 4 trials currently underway investigating the mortality benefit of screening with colonoscopy, and these will certainly be considered by the task force when the results become available. Unfortunately, the first of these trials won't be available for the next 5 years, and the other 3 in 10 years. I just want to remind people that we actually have a mobile app that's available that contains the guidelines and recommendations summary, knowledge translation tools, and links to resources. And so you can go to your app store to download that. So what are our take-home messages? 1, colorectal cancer is a common cause of cancer mortality, but it's something that we can do, we can have a positive impact on. We can reduce mortality from colorectal cancer. Screening with fecal occult blood testing and flexible sigmoidoscopy have been shown to decrease mortality from colorectal cancer in those aged 50 to 74. So our job is to go out there and make sure people get screened. Individuals over the age of 50 should discuss screening for colorectal cancer with their primary care providers. And patient values and preferences, test availability, and life expectancy should be considered in determining the best screening options for individuals. So there's more information on our website about this. I will be happy to take any questions.
Thank you very much, Maria and Donna. That was a very excellent overview of the evidence and the guidelines. Thank you very much. So we have another question so far, which is was posted at the end of, Maria, your presentation. So asking if you can comment on the fact that the studies showed reduction in colorectal cancer mortality, but not in all-cause mortality. Is it possible that the CRC mortality benefit is canceled by an increase in the risk of other things?
Thank you for the question. No, we weren't surprised. Oh, excuse me, I just have a bit of a cough here. Well, apologies, I just had to put you on mute there.
That's okay. Thank you, Maria. We understand Maria's a little bit under the weather today, so thank you for sharing responses despite that.
So that's a really great question. And first, we weren't surprised that we didn't see a decrease in all-cause mortality, such as things like cardiac mortality and so forth, because the size of these studies wouldn't be big enough to detect those differences. I'm interested, though, in the comment about whether or not they were canceled, the risk. Can the person asking the question elaborate? Are you getting at the fact that maybe because you have colorectal cancer, you don't get put on aspirin because you bleed, and that may increase your risk of cardiac disease? I'd be interested to hear a bit more detail on what you meant by that.
That's great. Thanks, Maria. And I'll watch the Q&A in the chat section to see if Mark can respond with any clarification of what he was meaning with that response. In the meantime, I'm just taking a look, and we don't have too many other questions from participants, but we do remind everyone that all of the links and material are posted in the chat section for anyone to access after the session, and we'll make sure that's available afterwards as well. I don't see a response so far. In the meantime, we will move the session on just to start our wrap-up slides. And we have our last polling question, which is, did you find the information presented today helpful? So we'll open up that poll question for attendees. If you strongly agree, are neutral, or you disagree. So that's great. We have quite a few people who are saying that they found the information today was very helpful, and I know it was very well delivered, so I'll have to agree with those participants. So, Mark, so we have a response from, to further elaborate on that question, Maria, and so for the canceling out component of that question, and he's just responded to say harms due to screening, I think was the increased risk he was referring to.
Oh, I understand now. The harms due to screening are actually very, very small. The risks of screening for things like perforation and bleeding are, I'll have to pull out that number exactly, are less than, I believe, 0.01%. Not sure if Donna knows that offhand, but again, very small risk. So I think that the reason we didn't see the difference is probably more related to the sample size and those studies for all-cause mortality. Donna, did you want to make any comments around that?
No, I agree that the amount of harms were actually quite small, and that we, in the review, we suggest that it is that the studies were not sufficiently powered to detect all-cause mortality.
That's great. Thank you both for your responses. That's really excellent. So in the meantime, we'll allow people to continue to post questions or comments. So just as we wrap up, we'll bring it back to our model of evidence-informed decision-making that we posted earlier. So we can definitely see that we've had a lot of the research side of this diagram shared with us today. And we've also had quite a bit of the application and guidelines. And we thank Maria for really presenting comparing the Canadian Task Force guidelines with the other guidelines. It was very informative, and it gave us a good context for the recommendations that we were hearing. We do have one more question, which is, are you aware of planned RCTs for fecal DNA tests?
That's an excellent question. There are definitely planned RCTs for colonoscopy. I'm not aware of any. Are you, Donna?
I couldn't direct them to specific upcoming trials, but I do believe that that's a strong possibility. I would need to go back. It's been a couple of years since we actually searched to see if there were upcoming trials. So again, if they wanted to contact me directly, I could do a little bit of digging and provide them with a more specific answer than what I've just given them.
That's really great. Thanks, Donna. And we'll make sure for all participants that your emails are posted in the chat section so we can, if any participants want to follow up afterwards with questions, we can guide them to you. So we'd just like to ask our participants if you have any next steps, so our last polling question of the day. So now that you've heard the evidence and guidelines, we have some few proposed next steps. You can access the full text systematic review and the screening guidelines. So again, we have those links in the chat section. Also accessing the health evidence critical appraisal for this systematic review. You can consider using the evidence within your practice and or telling a colleague about the evidence. So thank you to those who have responded. So we thank you, and Maria, maybe just one more question as well, and also to Donna, have you received much feedback from healthcare practitioners and any barriers to the guidelines that you've experienced so far?
I think the major feedback we've received is I think most people are getting on board with the fecal occult blood testing. A flexible sigmoidoscopy is certainly not feasible in most jurisdictions except Ontario. But even if we can get an increase in participation rate for fecal occult blood testing, that would be great. Most organizations such as Cancer Care Ontario have endorsed our guidelines, so we've gotten good support of that. If you also look at the commentary from the U.S., even though they recommend colonoscopy, most of the experts there agree with our recommendation, saying there's really no evidence for colonoscopy. So in terms of the practitioners, and the policymakers, they're supporting the guidelines, but it's still early, and we need to take a look in the next year or so to see if there's an increase in screening rates for colorectal cancer.
Absolutely, and it was really great to see the KT strategies that are being used to present the guidelines. So with that, I don't see too many more questions, so we'll just wrap up our presentation today. And if you're thinking about what you can do now, we have a few options on our last slide here. We welcome you to visit our website. So Health Evidence, again, is a repository of over 4,600 quality-rated systematic reviews. So our free searchable repository has evidence relating to the effectiveness of public health interventions. We invite you to register as a user on Health Evidence to receive monthly tailored registry updates, as well as our monthly newsletters where you can hear about upcoming webinars that we have. We invite you to tell your colleagues about Health Evidence and follow us on Twitter, where we actually post review findings daily from reviews in our repository. We'll also post about our webinar recordings and upcoming webinars. We encourage you to share Health Evidence with your organization, and we always welcome feedback and suggestions for future topics for webinars, so you can contact us. And again, our email will be posted within the chat section. So I'll leave it to Maria and Donna and ask if you have any last final words to wrap up the presentation today.
I'd just like to thank everyone for their participation and their great questions, and just remind everyone, too, that the important message here is that colorectal cancer is common. We need to encourage people to be screened. Thanks.
And I would also like to thank everybody for participating. And I just have one small comment to make to Mark, if he's still on the line. So, Mark, I went back to the review to look more specifically for an answer for your question. And what we say in our review so your question was, does the benefit of colorectal screening get canceled out perhaps by other risks? And so what our analysis showed, that although the studies were not powered to detect a difference for all-cause mortality, there was also no signal that all-cause mortality was increased. And if it had been increasing, that would suggest that the screening which decreases death from colorectal cancer was actually increasing death due to other causes. But so you can see that that's not happening for this group. So thank you, everybody.
That's really great. Thanks, Donna, for following up on that, that last question there. So a big thank you to Donna and Maria for the excellent presentation today.